in pregnancy. This is a tricky one right here. So you might put a little star. Probable and positive. It is one of those darn nursing healthcare things. I hate it. So we'll try and make that as straightforward as we can so that you can distinguish the signs of pregnancy. And then we'll finish up with emotional and changes in cultural factors that affect patient and her family. So obviously when you're pregnant, the reproductive system changes quite a bit. The uterus will enlarge. And then the other thing is we see this change in hormones. So again, as the uterus, but it's a gradual thing. So it's not like one day it's really teeny and the next day, whoop, okay? So I think that's why a lot of people, when they're very early pregnant, they do a very good job hiding it. You guys, I don't know, maybe you've seen the pictures of Meghan Markle, but the whole big thing now is she can't hide it anymore, okay? When the uterus gets enlarged, it actually takes that muscle as it gets bigger, it's like blowing up a balloon, it actually starts to get thinner. As it gets thinner, it actually will start to have some contractions. And those little tiny practice contractions, they're called Braxton Hicks contractions. They are mild, they are intermittent, they don't really hurt. Some women don't even feel them. But that's normal, that's expected. Now, we can listen with a stethoscope for the uterine souffle or the phonic souffle. Uterine is will get maternal heart rate, phonic will get fetal heart rate. No one I know of does this really anymore. It's mentioned in the book. Most of the time we just make sure, like when you're getting fetal heart rate, you check maternal's pulse and just make sure it's not the same. How could that possibly happen? Well, if mom's tachycardic, if mom's pulse is 124, and you're listening to the baby, you think you have the baby because the baby's running 125, 130. That may not be fetal heart rate you're listening to, it might be maternal heart rate. So you need to make sure there's a difference between the two. The other thing is if you have twins, you have to make sure you're getting each baby separately in terms of heart rate. The cervix will be made up of connective tissue, and remember it's going to be 1/12 of its pre-pregnancy strength. After you have a baby, your cervix doesn't really go back to its original shape. And again, if you have subsequent pregnancies, it tends to open up, dilate, soften, and efface faster. Why is that important? It's important if somebody is having their first baby, so maybe they're a primip. If they're a multip, their labor, there's probably going to go a little bit faster because their cervix is just going to open and ease up a lot faster than somebody having their first baby. With the cervix, because of estrogen, you're going to see increased mucus secretion. So you get this really glamorous thing called the mucus plug in the cervix. And a mucus plug is actually a good thing because it prevents bad things from getting up around the baby, primarily infection. Now, for some women, that mucus plug, they have a lot of mucus during their pregnancy. And it's like, ooh, this is so gross. It is slimy. It kind of looks like snot. It's white, but it's not itchy. It doesn't hurt. There's no foul odor. But some people, it's so much like they have to wear like a panty liner or something during their pregnancy. Sometimes they're coming to you and they're like, I don't know if my water broke, but it turns out it's just their mucus plug. A lot of women, they get really concerned because they might have intercourse, and then they're like, okay, did my water break? Is it my mucus plug? Is it just semen? I can't really tell. So they come see you in triage and you help determine what's kind of going on with the patient. So there's changes in the cervix. I would know what these are. Goodell sign and Chadwick sign. So how can you remember these? Well, this is a really lame way to remember these, but hopefully it'll help. So I think ice cream is good. Ice cream is soft. So the Goodell sign is like ice cream, which is softening of the cervix. Chadwick's, the only thing I can think of, remember a long time ago with the whole Chads, the hanging Chad, blue Chad, red Chad, right? Maybe you know a guy named Chad who wears a blue shirt, but Chadwick's sign is blue-purple discoloration of the cervix, okay? So it's very, so when if you were to look at it on a speculum, it would look almost bruised, and it's actually very normal. It's just from the increased vascularization. And again, generally we are not looking at the cervix with a speculum. It's the midwife, it's the nurse practitioner, it's the physician. Okay. But why is it important? It's because, again, this can cause some, if there's a problem, you can actually get a varicose vein in the vagina, believe it or not, very painful. So it's important to know if the provider sees anything abnormal there. But again, this is normal physiologic change that occurs in pregnancy. So the ovaries should be taking a break, okay? And why? Because estrogen's high. So FSH is in the basement. And you need FSH to ovulate because it has to mature the follicle, right? So ovaries really aren't doing anything. And again, I wouldn't say the ovaries produce, I think on the slide, you look at this and you think the ovaries produce HCG, and that's not what that means. What that means is that the ovaries are not really doing much, and the HCG tells you to keep the corpus luteum around, because the corpus luteum is an important player in the luteal phase, is what that's supposed to clarify there. The vagina has the same kind of changes that the cervix does. And you'll see this increase in vaginal discharge. So the medical term for that is leukorrhea. Leuko is white, okay? So increased white vaginal discharge. Very normal and expected. Now, the environment of the vagina becomes very acidic, again, to keep pathogens at bay. Unfortunately, that change in the pH of the vagina makes women at very high risk for yeast infections. So it's very common for pregnant women to get candida or thrush in the vagina. So the difference between normal leukorrhea and thrush, in thrush or yeast infections, it's white, it has a different texture, very irritating, itchy, red, can be painful. And we do typically tend to treat yeast infections in pregnancy. Okay. The breast change for a lot of women, sometimes that's their first cue that something has like, ooh, maybe I'm pregnant. At the beginning of pregnancy, the nipples may be very, very tender from the changes in hormones. The patient may say, oh, I can't even wear a bra, it hurts so bad. And that's, again, very normal. The breast will increase in size. The nipples get more erect, the areola gets darker. As you continue through pregnancy, stretch marks are also known as striae. They're not just on your belly, they can be on your hips, on your breasts. So the more distended the breast gets, the more likely you are to see those stretch marks. And I mentioned how you could have colostrum. And again, those may leak, but it's not a sign of whether you can or can't breastfeed or not. It's just in response to maternal hormones. So it's really nothing to be concerned about other than if you are leaking colostrum, you just want to have a pad and keep it clean and dry because you can't get infection in or through the breast. The respiratory system, moms have to provide oxygen to the baby, so they will have a little bit of hyperventilation occur to that. That can worsen as you go into labor if they don't do adequate breathing techniques. So one of the key things when you have a patient going into labor is to help them kind of slow down their breathing. If you have a patient who's hyperventilating, sometimes what will happen is they get dizzy and lightheaded, they get numbness in their fingertips. So sometimes you have to have them kind of breathe into their hands to kind of, again, get rid of that respiratory alkalosis that they're experiencing. In terms of what will happen during the pregnancy, the diaphragm is elevated. And what you're supposed to do when you're not pregnant is have diaphragmatic breathing. So the diaphragm lowers, the lungs expand. Well, now there's a baby in there, so the diaphragm can't go anywhere. So you switch from diaphragmatic breathing to thoracic breathing. But it's just not as efficient, okay? And so women get dyspnea, they get a little bit short breath because it's hard to meet both the oxygen demands of the baby, but also your increased oxygen demands. Now, when I say dyspnea, I mean pretty mild. I mean, you're walking up, you're in your third trimester, you're walking from Miles Hall up to Horrigan, and you're out of breath at the top of the steps. I'm not talking about sitting at home watching Jeopardy, being short of breath with your feet up on the couch, okay? That's totally different. So it should be mild, it should resolve, but again, I think a lot of women, it's kind of amazing, even women who were in very good shape prior to pregnancy. It's like, I used to be able to run, and I ran 5 miles, but now it seems like around mile 3, mile 4, I'm just tapped out, I just can't catch my breath. Well, that's normal, that's just part of pregnancy. Again, some medical terminology here. Rhinitis is the fancy word for runny nose. It's clear, okay? But again, it's that increased mucus secretion that occurs from the hormones. And then epistaxis is the fancy name for nosebleeds. Because of that increased vascularization, any type of irritation to the nose will cause nosebleeds, and they often are far worse than you ever had before. So again, normal and expected, but certainly if the patient's having a lot of problems with that, we want to talk to the healthcare provider about that. We really don't like using a lot of over-the-counter medications for allergies and things. That said, many providers here in our area, because the allergies are so bad here in our area, still go ahead and advise people to go ahead and take their, allergy medicine that they took prior to pregnancy. Again, in terms of the thoracic system, you're going to see this subcostal angle widen, okay? Pregnant women might have kind of more of a barrel chest appearance during pregnancy. So let's talk a little bit about asthma. We have a lot of patients with asthma in pregnancy. Now, because progesterone's in play, and progesterone relaxes the smooth muscle, that could help your asthma because you don't have bronchoconstriction. But you also have very reactive airways and you have a lot of mucus secretion. So some women actually find their asthma worsens. So there's not a clear cut. The key thing, again, for a patient who does have asthma, she needs to monitor it carefully, and she may need to modify her medications. And remember that a lot of those medications can cause tachycardia, and so if that's the case, we have to monitor both her and the baby. So in speaking of that, with the heart, oh my gosh, the heart, the heart, the heart. So you need a nice, healthy heart to have a good pregnancy. If you have a sick heart going into pregnancy, pregnancy is going to make it worse. Pregnancy puts a strain on the cardiovascular system. Most women do fine, but throughout the pregnancy, your blood volume is going to increase because you have to provide circulation for another human being. So you're looking at your blood volume is going to around 40–45%, which is amazing. So you have more volume, you have more cardiac output. And that's your body getting ready for the significant sudden blood loss you're gonna have at delivery. So it's, again, it's a compensatory mechanism, so it's normal and it's expected. A healthy heart can deal with that change. A sick heart cannot. So when I say sick heart, I mean somebody who maybe has a heart defect. Maybe they have an enlarged heart. In my domain, it has been IV drug users, because IV drug users have sick hearts and they don't do well with pregnancy. So the pulse may increase in pregnancy. Please add this little tiny note. When I say increase, I mean by about 10 beats per minute. Tachycardia is not what I'm talking about. You guys are okay with normal pulse, like 60 to 100? Tachycardia is pulse greater than 120. Does that sound familiar? Please tell me that sounds familiar. 62, so 60-100 is normal.
Yeah.
Pulse of 120 is tachycardia. You're making me nervous. I'm feeling a little tachycardic.
I've seen past 100, whether it's 110 or
Yeah,
I
I would say, and there are lots of things that can cause your pulse to change, but with this, we would not see tachycardia, okay? All right, the other thing is, during pregnancy, you may have a murmur because you've got all this extra volume and we can't get it shunted around, okay? It's usually benign. Everybody's okay with the term benign? Now, if mom, patient, is short of breath, fatigue, she feels heart palpitations, the test that will likely be ordered is echo, because again, we're looking at that blood flow through the heart. Okay. Now, blood pressure will kind of do a funky thing. So blood pressure does this. So at the beginning of pregnancy, it's what you've been running at kind of baseline. So there's not a lot of changes in the first trimester. But as you get to second trimester, it drops a little bit. And part of that has to do with the hormones that, again, decrease kind of vascular resistance, okay? And the volume is working on increasing, but it's not quite there yet, okay? It's not like you can say, okay, hematologic system, ciao, let's make more volume. It takes some time for that to happen. So while we're in this little window, the blood pressure drops slightly. As you get closer to third trimester, which is right around 28 weeks or so, we kind of are back to baseline. So as a student, what's the need to know? Hypertension is not normal in pregnancy. Okay, I'll say that one more time. Hypertension is not normal in pregnancy. Now, the other thing you can see, God bless you, is sometimes when my blood pressure's running lower, I'm feeling a little bit punier. And that's why sometimes at this point, if women are real susceptible here, they might see, again, concerns with orthostatic hypotension. In the third trimester, even though your blood pressure is back to normal, you're still at risk of orthostatic hypotension. And the reason why is now you've got all this extra volume. When you change position rapidly, I can't get all the volume from down here up here. And oh, by the way, there's a little obstruction in the way here called the baby. Okay? So orthostatic hypotension tends to be more of a later second trimester, third trimester phenomenon. And so women, again, get kind of dizzy, pale, and it happens with position change, rapid position change. So what do you do to prevent orthostatic hypotension? Change positions gradually. See what I mean? This OB stuff, some of it is not very glamorous. It is the basics. Now, also in the cardiovascular system, we could anticipate some dependent edema. Very normal, okay? Usually it is not pitting edema, and it usually gets better when mom has rested. So let me give you a clinical example. You have a patient who's a bank teller. She's 32 weeks pregnant. What trimester is that? Third. She says at the end of the day, her feet are swollen and her shoes are leaving little marks in her feet, okay? She goes home, she puts her feet above heart level at night. When she wakes up in the morning, swelling's all gone. That's normal, that's expected, okay? We generally do not restrict fluids on pregnant people. The other thing though is, for people who have severe edema, a lot of times we will try and put them on bed rest so that they're putting their feet up to help in terms of venous return back to the heart. Because they're concerned with that dependent edema. It's uncomfortable, it's painful, you don't get adequate circulation. It also sets you up for venous stasis, which puts you at risk for clots. Okay. So that's also this kind of congestion that occurs in the venous system, also gives you the symptoms of varicose veins. Vulva is in the vagina, the genitalia. Sorry, let me go back. Varicose veins in the rectum, that's a fancy word for hemorrhoids. Okay. All right, so I mentioned orthostatic hypotension. This is something different. Put a star and say, this is something different. And this is supine hypotensive syndrome, or vena cava syndrome. Vena cava syndrome occurs when the weight of the uterus is compressing the vena cava. Therefore, this usually happens, again, usually later in pregnancy, again, kind of the end of the second, beginning of the third trimester, mom's flat on her back. And so we don't want her flat on her back, so we tilt her a little bit to the side, shifts the weight of the uterus off the vena cava, and we get adequate circulation. That is different than orthostatic hypotension, which is a change from sitting to standing. The baby's not putting weight on my vena cava when I'm standing up. Does everybody follow me? I've had this argument with I do not know how many students, so I just want to make sure I am super crystal clear. If I'm standing up, the weight of the uterus is not putting pressure on my vena cava. But if I'm lying down flat on my back, that's a problem. So yesterday in clinical, you all talked about putting a wedge underneath your patient. Okay. So patient calls you frantic. I just woke up, it's 3 o'clock in the morning, I'm flat on my back. Did I hurt my baby? usually babies can tolerate it. The other thing is there's kind of a neat thing where the baby's like, that's uncomfortable, I need you to move, and mom will move. But moms often don't like being flat on their back because they start to feel kind of not so good and dizzy and lightheaded, so they're not comfortable with it, okay? What if I lay on my stomach? Hard for a person in their third trimester to do. I don't know, that'd be kind of challenging. But first trimester, am I gonna hurt my baby if I lay on my stomach? No. Again, there's lots of cushioning there, your baby's gonna be fine. All right, so we talked about the symptoms you can have with this. The other thing is if mom's on the monitor, the baby's heart rate starts having big D cells. And then in a few weeks, I'll ask you what type of D cell. But not today, okay? We talked about physiologic leukocytosis. Physiologic means normal or expected, okay? Leuko, white, cytosis, cell. Increased white blood cell production, okay? So I always tell everybody normal white blood cell counts like 5 to 10,000-ish, right? Remember that from old med surgery days? So with this, we're talking just a little bump up, not huge, maybe like 12 to 15-ish. So in the book, it talks about white blood cell count being in like 20 and 30,000 for a patient in labor. I don't know about you guys, but if I was a nurse and I saw somebody who had a white blood cell count at 22,000, I would be a little nervous about that. How about you all? So I think it kind of depends. If you have somebody who's been laboring on her own and the stress of labor, and by stress, the physical, right? Your body responds and your body's like, ooh, you're doing lots of work. So I think your immune system kicks in and it's like, okay, well, we need to make sure we're fighting infection. That's kind of different than somebody who comes in and she's getting an induction and she's getting an epidural and hasn't really been a lot of stress. So that I think you want to take some of your data and critique it a little bit. So again, just a little hiccup here with white blood cells. And again, we would not treat that with antibiotics. Can mom take antibiotics in pregnancy? Most of them. Some of them no, but most of them yes. Your platelet count doesn't change significantly, so our platelet count should be somewhere in the neighborhood of about 150 to 400,000 or so. Does that sound what you recall? Mm-hmm. Yes? Okay. All right. So we have this little condition called thrombocytopenia. Does that ring a bell? Mm-hmm. Platelet count is below 100,000. Miss McNeely, you're giving me PTSD because you're talking about med-surg. We gotta bring those things through. So if your patient had thrombocytopenia and she's pregnant, we are concerned about bleeding. Bleeding, okay? All right, why do I have a picture of water bottles on this slide? Well, it's because I used to bring them to class and everybody liked them so much and then I kept forgetting them. So I'm like, I'm just gonna take a picture of it and then that way I have it on my slide. So this is a crude example of physiologic anemia of pregnancy. So this is kind of what you start with, okay? And as you go through the pregnancy, the volume increases, okay? So the amount here increases. But the volume increases by about 50%, but the red blood cells do not increase by the same amount. So even though I have more volume, there's actually fewer red blood cells as a part of that. So what lab value is affected? I would say hematocrit is what I would say. That would be my best answer. I don't know. I think hematocrit might be the best answer. Because hematocrit is the percentage of red blood cells in the serum. And so again, everything increases, it's just that the red blood cells don't increase as much as the volume. Okay. Now, we pick this up, so we get a baseline when you're first pregnant, we check it again, but that's why sometimes women develop anemia, and we check that right at 28 weeks, so then they're on iron there at the end of pregnancy. Okay. That's also why we want to know hemoglobin and hematocrit when patients come in labor and delivery, because we're going to anticipate a drop. So my guess is there's folks here in this room who have hemoglobins of 11, which is low. As long as you're not having any symptoms with that, you're tolerating it, that's fine. But then if you're pregnant, as you progress, that hemoglobin might go to 10.1, something like that. Now you're feeling tired all the time, just kind of puny, so we might put you on a little bit of iron, okay? And you remember from med-surg land, we don't really like to transfuse people till we get to the depths of like 7, 6, 5, yeah, okay, all right. In terms of the GI system, you know, this is the one that everybody likes to alert about. You know, they talk about morning sickness. For a lot of women, it is all day sickness. It is not just morning sickness. The good news from OB land is that usually if you have nausea and vomiting, that's a good sign because your HCG levels are increasing. So that's kind of a reassuring thing you can advise patients is if they feel kind of queasy and have that upset stomach, that HCG level is what's contributing to that. Now, when I say morning sickness, all day sickness, we have to be very careful here because it's one thing if you up in the morning, but later in the day you can have a baked potato, you can drink liquids, you're voiding, you're having bowel, you know, we're not losing weight, okay, that's a good thing. But if you're throwing up so much that you're dehydrated, you're losing weight, that's a different, then we need to do some intervention with that. So you should not be losing weight in the first trimester. You really should be losing weight during pregnancy at all. But I think a lot of people are like, oh, well, I need to lose 20 pounds, so it's okay that I've lost 10 pounds at the beginning of pregnancy, and that makes me less worried about weight gain during pregnancy. Wrong answer. Because, think about it, if she's getting that sick, she does not have adequate nutrition, she's at risk for birth defects. Folic acid, okay? Women complain of altered taste and smell, things they didn't like before, they do like now. They're very sensitive to odors, and that can trigger the nausea and vomiting. So again, the household may need to change. Maybe every Friday night was taco night, and maybe it shouldn't be taco night for a few weeks until we kind of ride that. Many women get better after the first trimester because HCG levels start to kind of even out. We don't have this big whoom, whoom, whoom right there at the beginning. If you have twins, you have twice as much HCG. You got twice as much HCG, you got more nausea. Okay. Golly, that looks pretty official. Gingival hyperplasia. That is the fancy term for bleeding gums. It comes from estrogen. Okay. Again, we have a lot of vasodilation. You have increased vascularity there. So it happens everywhere, but it's really important that women get good oral hygiene during pregnancy. So you still can go to the dentist, we just don't want you to have x-rays during first trimester. If you need x-rays in the second or third trimester, that's okay, they'll just put a shield around the baby. But good oral hygiene is very, very important. So if you need dental work, you can still have that done in pregnancy. You have increased salivation, which can also make you more nauseated. A lot of women, as pregnancy progresses and we have, again, the stomach compressed, they get reflux, they'll have heartburn, and they have a lot of gas. So let's say you have a patient who comes in and she's complaining of abdominal pain. So abdominal pain from gas would be very, very sharp, constant, and would be alleviated with position or if she passes gas. Versus contraction pain. Contraction pain is dull, achy, it's intermittent, it comes and goes. There's a change in her vaginal discharge. We would advise women to avoid foods that cause a lot of gas during pregnancy. So broccoli, beans, spicy food, and again, small frequent meals rather than big, tumbleweed, all-you-can-eat buffet type things. Your GI emptying time and motility are decreased thanks to your friend progesterone. So that sets you up for constipation. Okay. And so with constipation, you have a decrease in the frequency, but really what changes is the consistency of your stool. It's harder and like rocks. It's very, very common for women to use stool softeners in pregnancy and also fiber to help with GI motility. The more constipation and straining you have, the more you're at risk for hemorrhoids. I haven't, and maybe there are, but I have not seen too many women get treatment for hemorrhoids during pregnancy. Usually they wait until the patient has gone through the postpartum period, has that recovery, and then if she needs any kind of surgical removal of hemorrhoids, they wait to do that later. The thing about hemorrhoids, they often will be present, the patient may not even know that they're there. Certainly when you are doing your postpartum care, you're looking to see if she has hemorrhoids, needs to have good care, good hygiene, use a spritz bottle, topical anesthetic agents to help alleviate pain with hemorrhoids. The other big thing in pregnancy that occurs from the GI system is gallstones. We're seeing more of that, and the patients who we see this in are the ones who tend to eat a lot of fast food. So they eat a lot of fast food. You're going to see more kind of sludge in the gallbladder, development of gallstones. Do you think a patient can have her gallbladder removed when she's pregnant? She can. Even with anesthesia, well, of course, this is not Game of Thrones. We're going to give her anesthesia, okay? We're going to do surgery. But ideally, we don't want to do that in the first trimester because that's the riskiest time for fetal development, okay? We don't want to wait till the very end because there ain't much room there. So it really needs to happen sometime in the second trimester, kind of between 20 and 30 weeks or so. All right, the urinary system. Women, when they first get pregnant, sometimes complain of urinary frequency. Let's distinguish that from UTI. UTI could have frequency, but also would have urgency, painful urination, dysuria, cloudy urine, foul-smelling urine. It looks like iced tea. It's nasty, gross. Okay. Again, if I'm not certain, I might do a UA, urinalysis. It's going to tell me about the stuff in urine, and if something's abnormal there, like a lot of white blood cells, then I might do a culture and sensitivity. You have to remember, a lot of our patients' urine specimens are contaminated because of the leukorrhea from the vagina. So again, I need to use those towelettes. I need a midstream collection. I don't want the very first urine. But all should be reminiscent of fundamentals. So she pees a lot at the beginning and then towards the end. As we get into labor, because again of the increased cardiac output, we get better perfusion to the kidneys, so we make more urine. So again, she's having to urinate a lot. We want to keep her bladder empty when she's in labor, so it doesn't kind of prevent the presenting part from going down into the pelvis. But if the patient's complaining to you, she's like, gosh, I'm going to the bathroom all the time. If it's just frequency and it's clear yellow urine, she's drinking lots of fluids, that's fine. So let's talk about the woman who's having to get up in the middle of the night and go to the bathroom. So we might do some things like maybe you should avoid drinking that latte at 8 o'clock at night. Again, where you have your fluids so that you get adequate rest. The other thing is you may need to get up and empty your bladder, but to try and just go easily back to sleep so they can have a good sleep pattern through the night. The GFR does increase, and it does remain, so again, there is some strain there on the kidneys, and that's part of the reason why we do a urine dipstick with every prenatal visit. The kidneys do the best they can with that, but sometimes what happens is you still have just a trace of glucose or protein, and that's very normal. We're not concerned by that at all. If I get into 1+, 2+, that gets more concerning, okay? So if I have glucoseuria, my concern is diabetes. If I have proteinuria, one of my concerns might be preeclampsia. There are some other things that could cause protein to be spilled in the urine, but those are the most classic symptoms: glucose, diabetes, protein, preeclampsia. Let me go back to this. Creatinine clearance. If we're concerned about creatinine clearance and the kidney function of the patient, they will sometimes do a 24-hour urine for pregnant women. So that's the brown jug. You keep all the urine for 24 hours. If you fill up one jug, you get another one. You keep it on ice, and you send that all in. So it doesn't need to be sterile because they're looking at the creatinine in the urine. Skin and hair, you'll notice a change in pigmentation. This often comes from estrogen. So they have chloasma, which is the mask. It's chloasma, the mask of pregnancy. So again, you'll start to see splotches, pop open. It's time to go. Linea nigra is the line of pregnancy. So that again is normal. It fades after the hormones change. You might see some spider veins develop, varicose veins develop. Stretch marks are real stretchy. They can be raised, red. They're uncomfortable. So there's lots of lotions and different things to minimize the appearance of stretch marks. One of the best things you can do actually is just to have kind of gradual weight gain. You see it in more stretch marks in patients who gain too much weight in pregnancy. So for example, if you have somebody who gains 60 or 80 pounds during pregnancy, they're gonna have a lot more stretch marks. They do tend to fade, they become kind of white silver lines when you're no longer pregnant. So hair is a funny thing. Hair can slow down in its growth during pregnancy, but some women actually say they feel like their hair is healthier in pregnancy, and I think some of it has to do with the vitamins that they're taking when they're pregnant. Postpartum, this is so glamorous, your hair kind of falls out in big clumps, and it's because your hormones drop so rapidly, and so your hair kind of has a different texture, and it's just different. So again, hair growth will change, but like women might notice they may not have to shave their legs as much if they shave their legs. That's normal and expected. Sometimes it's harder to reach down there anyway, especially at the end of pregnancy. Women will have acne, so they haven't had acne since they were a teenager, and they start to get breakouts on their face. There are certain medications that absolutely should never be used during pregnancy, like Accutane, so you have to educate patients about that. The other thing is they'll get night sweats. So for example, you're gonna talk to your patient when it's 40 degrees outside and she wants the air conditioner on and the fan on. And her partner's like, I don't know what's going on. She used to be so cold-natured. She was always the one who wore the sweatshirt and the blankets, and now she's sweating all the time. Again, very normal and expected in pregnancy. I put this on here just because it seemed like we kept getting patients in clinical who had pups. And I had students who are like, I keep saying my patient had pups, and that just seems really derogatory. And it's like, no, that they're not calling the baby pups. Pups is an actual like phenomenon. It's an illness. And it's where you get these little kind of itchy papules. It's a rash, and it's very uncomfortable, and it's often in your stomach. And sometimes they're so severe, there's not a whole lot they can do for them. They might use like some steroids to try and minimize the itching and irritation there. I have seen some unknowing ER physicians thought it was bed bugs. It was not bed bugs, it was pups. And again, it just has to do with, we don't know why some women have it, but again, it's from pregnancy. It's from pregnancy. And sometimes women actually have them in subsequent pregnancies. So you had it the first time, you might have it again in a later pregnancy. Musculoskeletal system. We see a change in how mom presents herself. So it's very common to form lordosis. So you do not want to confuse that with scoliosis or kyphosis. What happens through the pregnancy, there's actually a hormone called relaxin, and relaxin makes the joints looser. It actually can cause a slight separation of the symphysis pubis, and again, it's trying to make things kind of ready for childbirth. But women sometimes will notice that sometimes their balance, their coordination is a little bit different. They feel a little bit unsteady with their gait and balance, and some of it has to do with relaxin. We can see a separation of the abdominal muscles. Sometimes that continues into postpartum. For women, in terms of musculoskeletal, they have a lot of musculoskeletal pain. It's not uncommon to have paresthesias develop, numbness, tingling in an extremity. Carpal tunnel is a very common phenomenon in pregnancy. We really don't want to use opioids for pain relief, if at all possible. Obviously, opioids in any patient, we're trying to minimize the use, but at one time they were giving opioids to pregnant women for these types of pain, and that's kind of frowned upon now. So certainly positioning, simple comfort measures, some over-the-counter analgesics like NSAIDs or Tylenol. The key about over-the-counter medications is you just want to make sure that your healthcare provider knows what you're taking, how much you're taking, and that the patient's factual. So in other words, if the patient tells you, oh, I'm taking, Tylenol for a headache once a month, that's one thing. But if the patient's having to take Tylenol every day for a headache, something's going on there. We need to investigate that, because that could be a sign of something bad like preeclampsia. But this low backache, and again, it's kind of the waddle walk. People walk with their belly out and they walk like this. When patients are in, when they might lose their balance, we need to be very careful, so using things like the handrail, and then being mindful of when you might trip and fall, so with snow, ice, that sort of thing, so. All right, I think I got one more in me and then we'll stop. In terms of the endocrine system, it's an increased metabolic rate, okay? And so that is certainly, your thyroid is going to kick into gear. So we may see some changes in the thyroid. Some women do have some thyroid dysfunction in pregnancy. So I have seen some providers look at a thyroid panel just to kind of get a baseline at the beginning of pregnancy. Some women who have hypothyroidism prior to pregnancy, we just continue them on their thyroid medication because, again, there's more demand, but they may need an adjustment of medication. So it's not a big deal. The pituitary gland, we mentioned FSH and LH, but remember we're pregnant now, so those are not huge players. From the anterior pituitary, prolactin. Prolactin is a hormone that's going to be essential for us when it comes to breastfeeding, but you actually start making that during pregnancy, and that's one of the reasons you might have a little bit of colostrum leaking from the breast. And then the posterior pituitary gives us oxytocin and vasopressin. So you guys talked about oxytocin yesterday. Oxytocin causes contractions, okay, causes contractions. And again, some of those early contractions, not so bad, but we don't want them to be preterm. We don't want her going into labor and contractions before 38 weeks. Vasopressin has an antidiuretic effect, and it also keeps the blood pressure maintained so that we get adequate perfusion to the baby. So again, it's normal and expected. The pancreas is challenged in pregnancy. And so what we need to be really careful about is that there's an increased need for insulin. Again, that hormone, HPL, is antagonizing insulin. That hormone says, don't conserve, Mom. I need that energy for the baby and the placenta, for all the needs there. But a patient who needs insulin is going to need more insulin, particularly in the 3rd trimester. Okay? So if you're diabetic and you're on insulin, you're going to probably need adjustments in your insulin throughout pregnancy. But again, and some women were never diabetic before, and now they're diabetic in pregnancy. And again, it has to do with the pancreas isn't responding appropriately, and the placenta is producing HPL. All right.